Hello, thank you for coming to this press conference on healthcare. My name's Maxwell. I work for the World Economic Forum. Welcome to the World Economic Forum on Africa in Kigali, Rwanda. We are going to be talking about, we're going to be asking the question, how can Africa develop healthcare systems that are both efficient and cost-effective? I'm sat here with my colleague Arnaud Bernat from the World Economic Forum, who's head of our health team. I also have Dr. Osagie Ehanire, who's Minister of Health of Nigeria. I have Farouk Shamasjiwa of MSD. And we have Ahmed Sheikh Mohammed, who's County Executive for Health in Mandera County in Kenya. My first question to my colleague, Mr. Bernat, could you give some context? How can Africa develop healthcare systems that are cost-effective, efficient, and innovative?
Yeah, thanks, Max. So the first thing I would want to raise is that the one thing they should not do is to replicate the models that prevail in more mature economies. And that's where at the forum we undertook that initiative 3 years ago that we call leapfrogging healthcare in emerging economies. Just one point of context. If we were going to replicate the type of systems of OECD nations in a country like Nigeria, it would take to ramp up the number of doctors from 67,000 to 800,000. And guess what? It would take 300 years to get there. 300 years and 20% of the GDP. So, I mean, leapfrogging is about recognizing that the existing models can't be replicated and recognizing that new solutions need to be innovated. That leapfrog, actually, is a very expensive tier 2, tier 3 infrastructures of more mature economies. Examples, leveraging primary care networks, primary care clinics, with telemedicine, hub and spoke models where visual access to doctors can be implemented. At the forum, we are very proud in that in the past 3 years, we have been able to work in 3 countries, South Africa, Nigeria, and Kenya, in implementing solutions of that sort. Just an example. We started in Kenya only 8 months ago with the launch of the 6-county initiative. At this point in time, I'm very proud to report that already 6 leapfrogging initiatives have been enforced, put in place in public-private partnership between policymakers and the private sectors. Donations from Medtronics, Philips implementing a community life centers in Kiambu County, MSD funding multiple NGOs to test new approaches in maternal health and family planning, Safaricom Pharma Access developing mobile payment solution for health insurance on their platform, GSK joining recently the initiative and identifying at that moment the best way to engage. And UAE, also a partner of the initiative, developing telemedicine solutions. Those are leapfrogging solutions in motion, and we think that many more of them will help develop sustainable systems that are affordable and provide access to universal health coverage.
I think the emphasis here is very much on public-private partnership. So I think maybe can we hear from the private sector, our representative on the panel, Farouk Shamasjiwa of MSD.
Thanks so much. It gives me a great pleasure to say a few words here on behalf of Merck Sharp and Dome MSD. For those of you who are not too familiar with us, MSD is an innovative global healthcare leader committed to improving health and well-being of people around the world. And really at the heart of our access to health approach in sub-Saharan Africa is a commitment to discover, develop, and provide innovative products and services that save and improve lives while growing our business in a sustainable way. To your question, I think over the last 15 years of the Millennium Development Goals, there's a lot that we have learned as a private sector, and there's a lot that we have learned as a company. There are points of understanding in going from point A to B, but we also know that that line is not always linear. And that in that journey, greater impact and also the risks of failure are better hedged through innovative partnership and through leapfrogging. I think last year with the launch of the Sustainable Development Goals and at the same time the UN Secretary General's Global Strategy on Women, Children and Adolescents Health, there is really no better time than now to lean on our learnings and to innovate. And one recent example, as you rightly pointed out, Arnaud, is the Every Woman, Every Child Private Sector Health Partnership in Kenya, which was launched last year at the United Nations General Assembly. And as a founding member of the Every Woman, Every Child Partnership in Kenya, we signed on to that partnership, and I'm very happy to say that we have delivered on our commitment. Today, I would like to officially announce that MSD, through its MSD for Mothers initiative, will provide a $1.5 million grant to JPIGO, an international nonprofit health organization affiliated with Johns Hopkins University in the US, which will engage the Kenya Red Cross to explore and document innovative approaches to adolescent and youth sexual and reproductive health care in Mandera and Migori, 2 of the 6 counties identified in the Every Woman, Every Child Private Sector Health Partnership. The project will also inform the national rollout of Kenya's adolescent and youth sexual and reproductive health policy, and the project will also seek innovative partnerships with businesses in the 2 counties, including the Phillips Community Life Center in Mandera, which you also mentioned, Arnaud. I just wanted to make the point, to what Arnaud was saying earlier about the role of leapfrogging, and in particular, I would like to acknowledge the role of the WEF Leapfrogging Initiative, because they have been a key enabler of the Every Woman, Every Child Private Sector Health Partnerships effort, really helping to identify the right skills and the resources of the private sector, helping to guide and mobilize resources towards that effort, and really to make the Every Woman, Every Child Partnership in Kenya the best-in-class example of a partnership. And our investment comes 8 months after the launch of the partnership, and in my mind, it demonstrates how catalytic an ecosystem approach to partnerships can be in mobilizing collective action for health systems transformation with a noble cause and a defined purpose. And let's not forget that women and children, after all, are the future of Kenya, of the African continent, and the world. And frankly, it's time, I think, to move from commitment to action. So thank you.
Thank you. I think we would like to hear about the experience in Kenya. So I'm going to ask Ahmed Sheikh Mohammed, who's County Executive for Health in Mandera County Government of Kenya. What are you doing to minimize the risk of high mortality?
Thank you very much. I think before I go to the point of giving the view on how or what we have done, is first of all good to know the reason why we have that kind of high burden. These are regions within Kenya that has over the years been not getting any support from the national government in terms of healthcare, education, name any sector where that region was given kind of a blackout for reasons that are attached to historical past. But with the advent of the new constitution, and the devolved system that came into being after 2010 promulgation of the new constitution, the national government started investing because of the requirement by the constitution to make sure that the resources are devolved to those governments. In Kenya, we have 48 governments, 1 national, and 47 county governments, but 1 nation. We, because of the historical past, did have the worst maternal mortality ratio in the world, which stood at 3,795. It never happened anywhere, never happened in Sierra Leone, never happened in any other country that has had violent episodes as a result of conflicts. Kenya never had an active conflict either within, other than the post-election violence of 2007, 2008. That in itself is a reason as to why the national government stands charged for really not having taken responsibility of saving its own people. anyhow, after the advent of the new the county government, the new county government invested heavily, knowing the burden that we inherited, heavily in education and in health sector. For this reason, Mandera County government is strongly committed to developing affordable and high quality maternal health care services to its population. We decided to join the 6 county initiative spearheaded by UNFPA and supported by the World Economic Forum and many other actors, because it brings innovative interventions. It also brought international actors for more funding, like MSD, and also private sector coming to support the maternal health challenges. In Mandera, we have already started by setting up, community life centers, which is a cost-effective primary health clinic developed by Philips. And we are discussing the implementation of the telemedicine solutions with another international organization, Hawaii, among many other initiatives that we are trying to do to downscale. As we speak today, in the last 3 months of this year alone, just to see the impact, to gauge the impact of the 6 county initiative, we had, there was upscaled, access and utilization of the health facilities by the peripheral communities at the bottom pyramid. And as we speak today, I'm glad to report that we had about, out of 2,980 deliveries in the last 3 months, which it has never been the case before, there was only 1 maternal death and no child death reported out of the 2,980 live births that we've experienced. That in itself is a signal that the initiative that we have started together with many actors, UNFPA, World Economic Forum, and the rest, that actually is bearing fruit and the lives are being saved. Thank you.
Ahmed, maybe can I ask you to add only one point? The fact, how you funding the initiative and what has been the effect of the devolution process in Kenya?
Thank you very much. Before devolution, the funding to the entire county, not only health, the entire county, was extremely, peanuts. I mean, it was wanting. For instance, a sector like health got for a whole year to pay salaries, to buy, to purchase health products, and to buy equipment for health facilities, was not more than 50 million per year. But the first year of devolution, 2013-2014, the Mandera County government invested 900 million. In 2013, in health sector alone, from 50 million to 900 million. In 2014-15, the county government invested 1.2 billion in health sector, which was translated to 18% of the county budget, which is well above, the Abuja statistics that were given requirement. In 2015-2016, the county government invested 1.6 billion. In this current financial year that we have developed for 2016-17, 1.9 billion. So it continues to upscale. By giving more resources, we are also, upscaling our initiatives in health products, in health human resource, because we inherited a human resource of 150, both skilled and unskilled, in the entire county. Today, as we speak, we have 733 workforce. We just advertised a week ago to increase 200 more to be included, to our workforce. So we will continue recruiting our target, and that's why we have put aside that kind of resources in place to increase the workforce, the human resource for health, to 1,600 in the next, by end of this term of this government, which is up to end of 2017. By 2018, we expect to have about 1,600 workforce. And of course, we have also improved a lot of facilities. As in the next 1 week, we are operationalizing another 40 new facilities besides the 50 we inherited from the national government that were initially functioning. 3 out of 50 we inherited, 3 were functioning at 10% only. Today, we have 73 new facilities, all of them functioning at 100%, and 40 new more facilities are coming up. All this is as a result of the initiative of the devolution and also the 6-county initiative.
Thank you. I would like to also ask Dr. Osagie Ehanire about some of the challenges that Nigeria faces and how you're finding innovations to tackle those.
Thank you very much. Over the last few years, Nigeria has invested heavily, but in a higher healthcare level, at the teaching hospital level. And despite the investment, the health indices have not improved, they have stagnated. The focus of a new administration has been to reverse the trend and invest in primary health care, where the major disease burden actually is, taking health care to the people rather than the people to health care. The administration is planning to build one functional primary health care center in every political ward. That translates to nearly 10,000. Many of these actually do not need to be built, or rather to be renovated, because many of them had been in existence but fell into disuse. These primary healthcare centers will be equipped with potable water supply, renewable energy, and the staffing will be made up, depending on the area, in urban and cosmopolitan area, obviously, doctors, nurses, but in rural, hard-to-reach areas where historically doctors are reluctant to go, and where government previously said, well, if there's no doctor, then no health care. We are now changing tactics to train community health workers, purpose-trained community health workers, who will be selected from those same communities and will have no reluctance in working and remaining in those areas. There has previously been a high rate of attrition of health workers from areas where they thought were not hospitable. So the purpose of this is to now be able to create functional service 24 hours a day for the community, so that nobody has to walk more than or travel more than 5 kilometers to access health care. The quality of health care should be monitored technologically due to connection, e-health and mobile connection with a hub, general hospital that will be at the local government level, overseeing primary healthcare centers. The human resource, we have said, will be trained specifically to attend to these needs. And many of these needs actually are basic. We do not see primary healthcare essentially or only as curative. A lot of it is preventive. High disease burden comes from unsafe water, cholera, typhoid, which will be prevented if you have safe water. There are others that come from poor hygiene practices. So health education, community outreach, and enlightenment will be part of the function of the community health workers to educate the people on hygiene standards and also health promotion. On nutrition, there's a high incidence of nutrition in areas of the country, not because the food is not there, but because the wrong choices are made in food. And children are given food that is not nutritious for them. So health education will be carried out at this level, and then we believe also that another big problem to be solved is the vaccine preventable illnesses. We're talking about measles, rotavirus, diarrhea, and of course DPT, polio. All those are vaccine preventable illnesses and deaths which at the primary healthcare level will be addressed and to improve the total health indices for the country. Now, the funding of this, it is one thing to be able to set up these centers, build the infrastructure, build the human resource for health, but the sustainability has to be managed somehow by some financial arrangement. Nigeria has enacted Health Act, National Health Act, which provides for a fund of 1% of consolidated revenue to drive the sustainability. But this will not be enough. Nigeria runs a 3-tier government system where the states are being encouraged to also create a state health insurance facility, and even at the local government level to create community-based insurance. So you have many tiers where money will be pooled for risk pooling to drive this operation. The overall supervision will be at the level of what is called the primary healthcare under one roof, which brings together knowledge and operation from the federal, state, and local government. Now, partners here are indispensable. We look to multilaterals and to donors to help to complement this process, particularly in the area of this insurance, to build up membership, registration, and contributions by mobile payment. There is also the issue of governance, data reporting, and statistics management, where we shall require a lot of technology. I think referrals will go also from primary health to secondary and then to tertiary health level. So together we hope that all these will reduce disease burden and improve the indices in Nigeria.
Thank you. Do we have any questions? Can we have a microphone here, please? Could you say your name and the organisation you work for?
Thank you. Good afternoon. My name is Harriet Agbinyi. I work for Channels Television, Lagos, Nigeria. My question is for you, sir, Dr. Sage Hanire. You mentioned while you were speaking that doctors are always reluctant to go to some certain areas to serve. What is this administration doing to ensure that doctors are encouraged to go to those areas to serve and serve willingly, whether in primary healthcare centers, whether in the communities? What is this administration doing to ensure that doctors go to such areas to serve? Thank you.
Thank you. Do we have any other questions as well? Okay.
Well, in the first place, we have said that we have to recognize and proceed from the standpoint that doctors do not want to go to certain areas because they feel that they are far away, they are very remote, they do not have the comforts of life, they do not have the creature comforts that they are accustomed to in the cities. So rather than continue to expect that doctors will go there or compel them to go into those areas, we are creating a new approach, and that's the approach of purpose-trained community health workers who are trained to manage basic illnesses. As I've said just now, a lot of these is health education, sanitation, hygiene, and vaccination, which they can take care of easily. 60% of the disease burden in Nigeria is due to fever, and most of this fever is malaria, which they can also treat very easily. So with well-trained community health workers alone, you can take care of many of the problems which arise at the grassroots level. But then doctors are willing or will stay at the secondary level in the larger cities, at the local government headquarters. There is going to be a referral system that will transfer patients who cannot be managed at primary healthcare centers to the secondary facilities where they can have medical treatment. There will also be a portal where community health workers in rural areas will be able to access advice from doctors in the large cities to ask questions on diagnosis, on treatment options, and get professional advice in case they are in a difficulty in managing certain areas. So in this way, technology comes in to fill in the gap, creating a connection between a doctor supervising a certain number of healthcare centers without the doctor being physically present.
Thank you. Are there any other questions? I think I actually have a question for Arno. I mean, you've been focused on 3 countries. There's still a long way to go. What are the next steps?
Well, we've been learning a lot in those 3 countries, and notably, and that has been exemplified during the discussion today, this is never going to work if you don't have political will, if you don't focus on primary care, if you don't leverage and educate community health workers, focus on vaccination, and you need also to dedicate the right financial resources and make it a budgetary priority. When this is happening, then we can start launching a new leapfrogging program in another country. Our ambition is to become a platform for leapfrogging. So create the networks between public sector, private sector, civil societies to actually share best practices and implement new solutions, novel solutions. We would have to do that on a more systematic manner. We would have to do that as enabled by a platform that would be a connected platform, because in all honesty, it takes time to actually customize solutions, implement, measure, convene people, understand the priorities, redesign the solutions. Doing that in events as part of projects is good. It has created impact. There is no doubt about that. There has been considerable impact in Kenya and Nigeria. But if we want to do that in 10, 15, 20 countries, we need to implement a platform approach. And this is what we are committed to do as a forum as we structure our new platform for access to care.
Thank you. Sorry, we have one more question. We have literally 1 minute for this question, so please quick. Can you say your name and your organization?
My name is Victoria Rushizo from the Herald in Zimbabwe. I'm curious to know that where do you place Zimbabwe in all this? You said you want to go to 10, 15 countries. Is Zimbabwe part of the 10, 15 countries? Because somehow my country always lags behind, so I need to understand where this comes from.
That's a question for Arno, is that correct? Okay, Arno.
Yeah, I think we would definitely engage as when we find the criteria. And again, I mean, we need to be very rigorous in the selection of the countries where we can implement our approach, because we have found that when the political will is not coming from the very top, we fail. And but when we are going to find the political will and a clear focus on primary care, the acceptance that it takes task shifting from more skilled healthcare professionals to nurses, and from nurses to social workers, I think we have solutions to propose and to offer to such governments that would be interested to talk to us.
So a clear focus on political will and for primary care. Okay, thank you. Thank you, everyone.